everyone. This is the ORM, the first ORM Facebook Live. Oh, hi everybody. This is Dr. Rossi here. We're doing our Ohio Reproductive Medicine first Facebook Live event. And it's really great to be here with you guys tonight. And so what I thought I would do is just talk a little bit about the general kind of infertility evaluation. And I understand that if maybe a lot of you that could be watching right now maybe have already had an infertility evaluation, but I gotta tell you, we do this every day and we think about this all day long and we know all the words. Hey everybody, we know all the words that we're saying all the time. But I know that sometimes it takes a couple times to hear things before you totally understand them. And sometimes different doctors explain things in different ways. And so, maybe if you're my patient, you'll hear things in a new way that I say, or if you see another one of the doctors here, you might have a different understanding of something too. So often, when I see people in the office, I'm actually going to talk to you real quickly about what it takes to get pregnant. And I know that you all know what it takes to get pregnant, but really what I mean is what it means to actually have all the things in the right place. And so essentially what needs to happen to get pregnant is the brain and the ovary need to communicate back and forth. The brain tells the ovary by sending hormones to make an egg. That egg grows and it gets released. That's called ovulation. And then the fallopian tube has to actually be able to pick up the egg, and then the egg moves carefully through the fallopian tube, and then that's where the sperm meets the egg. The egg is fertilized in the fallopian tube, and then that fertilized egg travels through the rest of the fallopian tube and implants on the wall of the uterus. And so our infertility evaluation is basically geared around looking at each one of those steps. And so, to look for ovulation, we may do hormonal testing. And sometimes we have a good sense of if people are ovulating just by talking to them and them, do they have, does the woman have regular periods? Or are they irregular? Are the cycles long? How many days, does it take from the time of ovulation until she has her next period? So those are some of the things that we talk about to try to identify if there is any hormonal issues going on. The next thing that we think about is the ovary. And it may be worthwhile to just spend a minute talking about ovarian reserve testing, because I think that this is a really confusing part of the infertility evaluation. So there are a couple different ways to look at ovarian reserve. And ovarian reserve is an idea about how many eggs a woman may have left in her ovaries. And ovarian reserve, so these levels like an AMH level or an FSH level talks about how many eggs are left. It doesn't necessarily talk about the quality of the eggs. So that probably age is a better determinant of sort of egg quality, and the ovarian reserve is an idea about how many of the eggs are left. So for example, we may have a 34-year-old woman who is told she has low ovarian reserve, and that could be true, but she probably still has very good egg quality because she's less than 35. And the ways to look at ovarian reserve can be by doing a day 3 FSH and estradiol level, by checking an AMH level or an anti-Müllerian hormone level. Sometimes they'll you'll also have what we call a pelvic ultrasound to look at an antral follicle count, and those are all ways to look at ovarian reserve. And the other thing I want to make sure that people understand is ovarian reserve testing is very important. Actually, it's really important when we think about preparing someone for an in vitro fertilization or an IVF cycle, but it doesn't necessarily tell us that that's the reason why the woman's not getting pregnant, or it doesn't predict her risk of miscarriage, or it doesn't predict menopause, or it doesn't predict her risk of having a child with Down syndrome or anything like that. So sometimes it's hard because people are told they have a low AMH level and they're trying to understand if that's really the reason why they're not getting pregnant. And oftentimes it's not, but it can guide us a little bit in sort of understanding other testing that may need to be done, or understanding, what kind of, how fast you should go through treatment, and sort of any other medicine dosing that she may need. The other thing to think about is doing a fallopian tube test, or an HSG, or hysterosalpingogram. That's the x-ray test to look at the tubes to make sure that the fallopian tubes are open. The other kind of caveat to the HSG is that it's important to remember that sometimes just because the fallopian tubes appear open on HSG, it doesn't necessarily mean that the tubes are functioning properly. Remember, like, that fallopian tube has to be able to pick up the egg, and the fallopian tube has these little, like these almost like little teeny, like hairs in them that kind of move, that make a current and kind of move the egg through the fallopian tube. So sometimes if people have had infections before, or have had, pelvic scarring, the tubes can get scarred and don't function properly. So it's important to, talk to the doctor if you, let us know if you've ever had any infections in the pelvis before. Sometimes we'll also do a pelvic ultrasound to look at the uterus, to look for fibroids or polyps. And then, often if the couple, if there's a male partner, then we would do a semen analysis to look at the quality of the sperm. And the semen analysis looks at the volume of the semen. It looks at the amount of sperm that are moving, and it also, the amount of sperm that are there, and then how well they're moving. And so that's the basic infertility evaluation. I'm going to just spend a couple minutes just looking at some of the questions that people are sending in. So one of the viewers has a really good question about if there's a way to look at the function of the fallopian tube. And I have to tell you, that would be such a great test if we had that. We don't have a way to see the function of the fallopian tubes, because I guess when I say function, I mean the ability of the egg to move through the tube, and the ability of the sperm to get to the egg, and also the ability of that egg to even get picked up by the fallopian tube. So one of the things I find, and maybe we don't do a good job of educating patients about this, but I feel like when you look at pictures of the pelvis, like when you look at pictures of the fallopian tubes and the ovaries, it looks like the fallopian tube is attached to the ovary, and in fact it's not. They're near each other, but they're not connected. And it's this amazing thing that happens where the fallopian tube has these really, really interesting little hairs at the end of them, and they make a current and they pick up the egg, and then the egg moves through. And unfortunately, there isn't a little camera we can put in the tube or look at the tube to know. So it's hard to know if the tube functions. I would say the other way that we sometimes know is, we have a lot of patients who maybe have had pregnancies, and maybe they've had a very early pregnancy loss, or have had a biochemical pregnancy, or a very early miscarriage. And sometimes the fact that a pregnancy has occurred lets us know at least that the fallopian tube was able to get the egg, right? So, but unfortunately there isn't any other great test to look at tubal function. And it looks like, I'm just reading, sorry, I'm looking at this question here. Okay. One of the questions that has come up, which I think is a great topic, and a topic that I'm very interested in, is about polycystic ovary syndrome. So PCOS is considered the most common hormonal condition among reproductive age women. And so it's very common. We see it all the time. And sometimes it can be tricky to diagnose. And so it's not uncommon for us to see patients who say, somebody told me I had PCOS, and then some other doctor told me I didn't have PCOS. And PCOS it's not just like a disease that you can just do one test and say, oh, you have it. It has to be a constellation of a couple different symptoms, including irregular periods or cycles that are spread apart, having hair growth, acne, or elevated androgens, which can be androgens from the adrenal gland, something called DHEAS, or testosterone, which is made in the ovary, and having a lot of little tiny antral follicles on ultrasound. And some of the best ways to deal with PCOS is to make sure that first I would say to make sure that you have an appropriate diagnosis. So if you feel like, you read about it and you think you have it, but maybe your doctor's not listening to you about whether you have it or not, maybe seek a second opinion and see if in fact you do have it, because it does change our treatment. Over time, PCOS has been treated with Clomid, and it's been treated with letrozole, and it's been treated with metformin, and it's been treated with surgery, and all these different things. But the standard of care right now is, if there's no other fertility issues going on, is to think about using a medication called letrozole. The other name for it is Femara. So that's usually the standard of care for patients with PCOS. And then some of the other things that have been really found to be helpful, a lot of patients with PCOS struggle with their weight, and even a mild to moderate weight loss can really lower insulin levels, which can kind of change the hormonal imbalance with PCOS and allow people to ovulate more easily. And so, the cornerstone of PCOS management can be diet and exercise, Femara, sometimes metformin. But that's definitely, if there are any other fertility issues, sometimes we do end up doing other treatments as well. So I'm just looking at, so back on that same issue with the insulin, I do think that as best you can for patients who have PCOS to try to even do lifestyle modification to try to get weight down, insulin levels down. That may help your overall success with infertility treatment, including things like insemination. There is a patient, or I say a viewer, who has a question about cancer. If a patient has a history of cancer, does that affect their fertility? And it really depends on what kind of cancer the person had and what kind of treatment they received. So for some patients who have had cancer in their pelvis or had surgery in their pelvis, that sometimes can cause pelvic adhesions, which can affect fertility. Sometimes patients have had, if they've had brain surgery or like brain tumors and brain surgery, that can sometimes affect their pituitary function. And the pituitary is very important for controlling ovarian function. So that can sometimes be an issue. And sometimes if patients have had radiation to their pelvis, that can affect ovarian reserve or ovarian function. And so not all and it really also depends on how old the person was when they had cancer therapy, and so the age that they had it, and the type of treatment. But I would have to say, if there's any question, if the cancer patient is out there and they have any question about their fertility, at the very least, just check in with a doctor, either your regular doctor or a fertility doctor, because it never hurts to have a conversation about it, and maybe do some ovarian reserve testing or kind of talk about a game plan. You just don't want to find out, in your late 30s or 40s that, you did have ovarian, reserve affected by, maybe the cancer treatment. I'm just looking back here at some of the questions. One of the questions, back to PCOS, patients with PCOS seem to have, somebody asked a question about, I'm going to say PCOS and maybe miscarriage risk. I have seen studies in the past that have showed that patients with PCOS may have a greater risk of miscarriage, and they're not all conclusive. So, I don't want to kind of say this too strongly, but I have seen studies that show that there's a greater risk of miscarriage with patients with PCOS. Unfortunately, we don't know exactly what to do about that, meaning that there hasn't been conclusive evidence that, taking metformin will help that, or, I don't know, taking this medication or that medication will help that. So I think that I would say that there may be a suggestion that patients are at higher risk for that, but unfortunately there's nothing that, has been proven to reduce that risk of miscarriage. I'm sorry, I'm just looking up here, you guys. There is a question about one of the things I I want to just talk about is there was a question from one of the viewers about C-section and the risk of infertility. And this is a little bit of a tricky question. And I would say in general, most patients who have had a C-section do not have a greater risk of infertility. And so I don't want to scare anybody who's had a C-section. There was a study that I saw recently that showed a slightly greater risk of what we call secondary infertility. So secondary infertility is when a woman has gotten, or when a person has gotten pregnant before, but is having trouble getting pregnant the second time, or after that, I would say. So I did see a study recently that showed that there's a slightly greater risk of secondary infertility among people who have had C-sections. Now, you also have to remember that like my viewpoint on this is a little bit skewed, right? Because I don't see any of the people who had C-sections who don't have any problems getting pregnant because they're all getting pregnant without our help. But I do sometimes see patients who are having trouble getting pregnant after having a C-section. And it's kind of tricky to know, like, is it the C-section? Was it something that happened at the time of delivery? Like, did the patient have a an infection at the time of the C-section that is affecting their ability to get pregnant? Sometimes other things have changed in her health. Maybe she has gained weight and that is affecting her fertility. Or maybe there's another issue with her partner and that's affecting her fertility. So I would say that, if a woman's had a C-section and she is, she's ready to try to get pregnant again, I think it's reasonable to try. I would just, have a low threshold to seek help, if it seems like it's taking longer than it did the first time. One of the questions we have is about seeing one of the infertility specialists here at ORM, and we're always happy to see patients who are new to the area. You can always kind of check with your insurance about whether you need a referral or not, but a lot of our patients don't see an OBGYN first. They maybe talk to friends or family members, or they're, everyone's reading on the internet too about different things. So you can often see us just without a referral or anything. So does anyone else have any questions right now? I'm happy to take more questions, or else I can talk a little bit more. Let's talk a little bit more about, let me just talk a little bit about in vitro fertilization, because I think that this is obviously, you know what, before we talk about IVF, let me talk about something else, because I think that I'm trying to think of things that are kind of common questions that people have. One of the things I want to talk about is something called embryo testing, and preimplantation genetic testing is one of the things that I just want to talk about. So that is, we call it PGT-A or embryo testing, all kind of the same thing. I just want to talk a little bit about that. So the most common reason why we think people don't get pregnant with IVF, or the most common, issue as women get older, is that the egg doesn't have the right number of chromosomes anymore. And that's why as women get older, they have a higher risk of miscarriage or a higher risk of things like Down syndrome. And so the thought with this testing of the embryo is, hey, well, maybe if we could test the embryo before it goes into the body, we'd be able to find out if the embryo was normal or not. And if the embryo was not normal, we won't put it in the woman, and then she won't have a miscarriage, and we'll only put the normal ones in, and then she'll have a higher chance of having a baby, and everyone will be happy. And so this idea about testing the embryos before they go into the body, it's been around for a long time. It's probably been around for, 15 years now or so. And it's changed over the years in terms of how they do the testing, and the name of it has changed over the years too. And now, I think it can be a little bit tricky because there's different kind of doctors tell you different things about it. And, I'll be very honest, I'm probably a little bit more conservative with the testing. And, you could talk to a doctor in, California who does it on all the patients because they may feel differently about it. But there was a very good study that came out, and this, by the way, is very controversial in our field. Like experts in our field have been fighting about this for for years and years, and so it's quite controversial. And there were some studies that came out over the last few years. Some of them had showed no difference between success rates or the ability to get pregnant while whether people had the embryo testing or not. And some of the studies maybe showed a suggestion of it being helpful if women were kind of in their late 30s. And so it can be questionable about sort of how useful it is. So the risks of doing this genetic testing are that some people worry that the embryo can get damaged from the biopsy because they have to biopsy the embryo to get the cells. There's always a very, very small chance that the test could be not accurate. And there's also, it adds cost. So sometimes even if people have fertility coverage or infertility treatment coverage, sometimes it wouldn't be, this testing actually wouldn't be covered by insurance, and it can be several $1,000s. I would say on the flip side, the good thing about it is that, if it works for that particular patient, then they might have a higher chance of getting pregnant. They might not have a C-section, and it might get them pregnant faster. And so, it's important, I think, and it's totally fine. Like if a couple decides that they want to do it, I think it's absolutely okay to do it. We just usually want to make sure that people understand that it's not a perfect science, that it can still have some limitations, but it is definitely a tool that, I think we continue to improve on. And now they're doing all kinds of cool technology now where they're trying to figure out ways to look at the genetics of the embryo with what they call non-invasive testing. So, we all kind of worry about, does it hurt the embryo to biopsy it? And so now they're trying to figure out how to do testing of the embryo by looking at the fluid around the embryo as it's growing, so we don't even have to biopsy it. So I think this idea of trying to get information about the embryo before we put it into the body and then using that to help people have a higher chance of getting pregnant, I think that concept and that idea is definitely a direction that we're going in our field, and I'm really looking forward to seeing kind of what happens in the next few years with that. Oh boy, something wrong, you guys, with this. I'm reading your notes now. Is anybody having trouble refreshing this? Let's see. Oh no. Can somebody let me know if it's better now? Okay, it looks like okay, maybe everything's looking. I was so worried about this that I came back to my office tonight. So I think I'm in a place where there's a pretty good connection. It looks like one of our, okay, maybe we're getting back on track here. Yeah, just keep me posted, or somebody let me know if there isn't anything that I can do. So I have a question that came in, which I think is a really good one, about something called, so this is kind of in the category of IVF again. One of the patients had a question about something called an ERA. Okay. A question about an ERA, and an ERA is something called an endometrial receptivity assay. And so this is used during an IVF cycle, and the idea is to assess the receptivity of the uterus. So I don't know if you guys understand, you probably do, but let me explain this to you. So when we're doing IVF, or quite frankly, even in natural fertility, everything has to be timed really perfectly. It's all in sync. So the egg gets released, and as soon as that egg gets released from your ovary, the ovary starts making progesterone, and then the progesterone starts to change the lining of the uterus. And there has to be a certain amount of time that the embryo, there has to be a certain amount of time that the uterus is exposed to progesterone so that the embryo can attach to the wall of the uterus. And this is why we're exceedingly careful about during IVF about how many hours of progesterone someone has been on before they have their embryo transfer. Or we check your progesterone level on the day of your egg retrieval because we want to make sure that there hasn't been an early exposure of, the uterus to progesterone. And so in endometrial receptivity assay, the thought is that they're looking to make sure that the receptive window is appropriate for the person. And so, we know from studies of, people doing evaluations on timing of progesterone over years and years of doing IVF, we know sort of how many hours. So we actually talk about hours. I know it seems like we're just putting you on, X many days of progesterone, but we're thinking about hours. So how many hours a person needs to be on progesterone to make the uterus receptive so that we put the embryo in the uterus at exactly the right time of receptivity. And, it's theoretically possible that maybe somebody's body isn't like everybody else's body, and maybe they metabolize the progesterone differently or whatever. And it may be that their receptive window is different. And so an endometrial receptivity assay tries to assess that. It tries to assess, in that particular person, do they need more exposure to progesterone before they're receptive, or do they need less exposure to progesterone before the uterus is receptive? And so essentially how it works is often people will do kind of like a mock cycle or a mock frozen, and this is only for frozen embryo transfers really that we do this. You do like a mock frozen embryo transfer cycle, and instead of transferring the embryo, they actually will do a biopsy, an endometrial biopsy of the lining of the uterus, and then we would have it analyzed, and it will tell us if that was done in the receptive window or whether it needed to be earlier or later. The data on endometrial receptivity assays is kind of mixed. Some of the studies show that it may be helpful. Some of the studies show that it's not helpful. I think that when we have patients who have had, multiple embryos transferred and it's not totally clear to us, why they're not getting pregnant, sometimes we do it. It's often a test that's not covered by insurance, and it can be, somewhere in the ballpark of like $500 to $1,000. So it can be kind of an expensive test, which is one of the hesitations we have with doing it. But it's definitely, a tool that we use sometimes for patients who maybe haven't gotten pregnant with either a genetically normal embryo, or someone who's had like several really nice embryos and hasn't gotten pregnant. All right. So let me just see here. Hold on. Okay. Someone has a question about nutrition and IVF, or nutrition and fertility. I really wish that we had so much more information on lifestyle and IVF. And I throw everything in the lifestyle. Like in lifestyle, I put diet, exercise, sleep, supplements, coffee, smoking, alcohol, all that stuff. Because I think that having infertility and doing infertility treatment feels like you don't have any control over anything. And, sometimes these little things that we do every day they're the only things that patients can change, right? So I wish we had so much more information on things that patients could do, like diet and exercise, and know sort of what was the right thing to do. I think in general, if you were trying to have a healthy diet, usually we would say, maybe try to watch your carbohydrate intake, watch your sugar intake. I think trying to get, good proteins and, whole foods and good fats. And I say good fats, like plant fats, nuts and avocados and that kind of thing. I think are all good before you do IVF. Remember too, some people wonder about, if you're going to try to do some lifestyle modification. Any positive lifestyle modification is good, but truthfully, the egg that we get during an IVF cycle started being made about 3 months ago. And so it's never a bad idea if you're kind of thinking, gosh, like, I want to do IVF. I don't know when to do it. I need to, I want to try these different lifestyle things to really make my eggs good quality. Sometimes the right thing to do is to give it a couple months and really try to make sure that, all these positive things have a chance to really, and the same is true of sperm too, has a good chance to really make sure that you get a good benefit from it. But, I think that best diet and exercise is to just do, try to have a healthy diet, try to watch carbs, try to have whole grains, full fat, all that stuff, and just try to rest when you're doing IVF. It's a tough process to go through. Try not to overschedule yourself. I mean, obviously people are working and we know that, but just try to do your best to kind of keep, not really drink during IVF. Obviously don't smoke. Caffeine, you could probably drink 1 glass a day. When I say glass, I mean 8 ounces, not 20 ounces. So just try to be as healthy as you can through the process. Okay, this is a good question. Hi, everybody who's saying hi. It's nice to see all of you too. Okay, so one of the questions is, does age impact a man's fertility? So we don't know as much about men as we do about women. I mean, I think we know that there's something called age-related fertility decline for women. One of the first questions for men is, like, what's an old man? Like, I don't even know if we know how to define that. Like, is an old man over 40? Is he over 50? Is he over 60? So we don't really know that. We do see some increased risk with men and increased age. It can be, and it's not necessarily like, it's some, not the same things we see with women. Sometimes there being a slightly higher risk of birth defects or other chromosome issues, not like the Down syndrome and stuff that we see. So I think, with men's fertility, I think it's always just important to make sure that we evaluate men too. I mean, there's really been a big movement in our field, within the last couple years to have men see urologists if possible. Like, if you have an abnormal semen analysis, sometimes that can indicate that there is something else going on in the man's life too, like it's affecting his overall health. So we want to try to stress that they get evaluated as well. I don't know. I mean, sometimes there's a couple and maybe he has a kid who's 7 and she's never had a kid before. And so the guy's like, oh yeah, it couldn't possibly be me. But, I always say, well, it's been 8 years since he got somebody pregnant, so it's always important that we have the men be evaluated and recognize that there's a lot of things that can happen with sperm quality too. And sort of understand that needs to be addressed. Okay, so there's a question about endometriosis. So endometriosis is another really common condition, and a lot of times I feel like it kind of falls into the category of PCOS, and like, endometriosis patients also sometimes have seen multiple doctors and have never had an appropriate diagnosis, and it's probably more common than we think. So let's just spend a minute talking about endometriosis. So endometriosis is a condition when, like, the cells inside the uterus, like the endometrial cells, they end up in other parts of the pelvis. And, this may happen because of during development, like literally when the patient's developing as a fetus herself. It may be that there is a blockage somewhere where instead of the blood coming out of her during her period, it kind of backs up into the tubes and implants on the uterus or implants other parts of the pelvis. But it's very common, and some of the most common symptoms are pain with period or chronic pelvic pain, sometimes pain with intercourse, pain around the time of ovulation. And often these women, I mean, sometimes the pain is really, really bad. They can't work, they can't go to school. Sometimes they have to take pain medication. And a lot of times this is pain that has been around even since they were a teenager. And, sometimes what we'll see is patients, let's say they're 20 years old, they go on birth control pills, and all of a sudden the pain goes away. And they live for 10 years on birth control pills and they're doing okay. And then they stop the birth control pills and all of a sudden their pain comes back as they're trying to get pregnant. The important thing to understand is that the only way to truly know if somebody has endometriosis is to do surgery, usually a surgery called a laparoscopy, to go in and look for it. Sometimes we see suggestion of it on ultrasound by, maybe seeing endometriosis cysts in the ovaries. And there probably are a lot of patients out there who are told that they have unexplained infertility, and really they may also have a component of endometriosis, is that we just don't know for sure because they never had surgery, because a lot of times we don't want to do surgery to look for it. And so, if we suspect that somebody has endometriosis, a lot of times they can kind of move ahead. In some ways, the idea is to just get them pregnant as quick as possible so you can try to suppress the endometriosis. So as long as they have open fallopian tubes, and as long as they don't have any significant ovarian cysts, and they can tolerate trying to do medication, sometimes they'll just do Clomid and IUI and see if it works. But many patients who have endometriosis will end up doing in vitro fertilization, especially if we think the endometriosis may be affecting the pelvic anatomy and maybe making it hard for all that, we talked a lot about the egg getting into the fallopian tube. Sometimes endometriosis makes that all a little bit harder to function. So sometimes those patients end up doing IVF. And, what we do with endometriosis patients and IVF kind of changes over time. Much like any other infertility treatment, like anytime we give patients medicine that get their ovaries going, like it also grows the endometriosis. So we have to be really thoughtful about that. And so sometimes patients will go through IVF, they'll have a fresh embryo transfer, and they do fine, and that endometriosis patient can do fine. Sometimes people will try to suppress the endometriosis before they do a frozen embryo transfer cycle. So if we know that someone has endometriosis and they're having a lot of pain, or we know from surgery, let's say they have frozen embryos, sometimes they will suppress, like sometimes those patients will maybe be put on birth control pills, or be put on something called Lupron, or be put on letrozole to try to suppress all the endometriosis before we do a fresh or a frozen embryo transfer. And so there's a couple different things that we sometimes will do with endometriosis patients. Usually we try to avoid surgery if possible, and most of the time we can. But sometimes if patients need to have surgery even before they can do IVF. Okay. One of the viewers has asked about the the chance of what we call a heart-shaped uterus and carrying a child to term. So what we're talking about is, you guys excited? I brought my dry erase board just in case we needed it. Okay, so let's talk about what this viewer has a question about. Okay, so what we're probably talking about is something called a septate uterus, or a septum. So if like this is a normal uterus, see how this kind of goes down in the center? That is called a uterine septum. And so sometimes people are told like heart-shaped uterus because it kind of looks like a heart. The other name for this is an arcuate uterus. Arcuate kind of is like the term we use when it's maybe not a severe like a septum, like it's not as long as a septum. And then sometimes patients are told other things that are kind of in that same category. Like sometimes patients are told they have a bicornuate uterus, or they're told they have a double uterus or something. So sometimes patients will come to see us and they'll say, oh, my doctor did an ultrasound and they said I have a heart-shaped uterus. Like, what am I supposed to do? And that, among other things, is also controversial in our field. But if someone has a very deep septum, and I say deep, let's say it goes all the way down, kind of like to here, those patients can be at greater risk for things like a preterm delivery. They can be at greater risk for a miscarriage. They can be at greater risk for needing to have a C-section because the baby might be breech. And so, it kind of depends on what the patient's history has been. If somebody shows up to us and they say, I've had 2 miscarriages, and now I've found that I have this septum. Well, that might be a reason for us to fix it. And when I say fix it, what I mean is some patients will have a surgery called a hysteroscopy, where we literally can go in, like we put the camera in this way, and we actually just kind of remove it so that it looks more like that. And so then we get that area out of the way so the pregnancy doesn't implant on it. And if it doesn't implant on it, sometimes you have a lower risk of having a miscarriage. If it's found kind of incidentally and the patient hasn't even really tried to get pregnant, they just kind of found it, when they were doing an ultrasound for something else, it can kind of get a little tricky to know how, what to do, if anything, with them. And so sometimes we watch them. They don't change. So if somebody has that, they were born with it, it's never going to get any smaller. It's never going to get any bigger. The idea is to sort of talk with your doctor about, whether it's something like kind of the risks and benefits of deciding whether there needs to be an intervention like surgery for it. Most of the time, if they're small, and that's also, like I said, people are fighting about that in our field right now as well. All right, someone's asking about coffee. You can have like 8 ounces of coffee. It should be fine. Okay. Let me see here. Somebody's have a question. Let's see. Okay. One of the patients, one of the viewers has a question about kind of this idea about age-related fertility decline. And in general, like if you ask me, like in the population, like in the, when does age start to go down? When does fertility start to go down? It probably starts to go down like 34, 33, 34, somewhere in that range. And, you have to kind of, as you're trying to figure out what to do with your, like if a couple's sitting there and trying to figure out like how they're going to build their family and how many kids they want. I mean, I always feel bad because one of the things, I never want to bother people, but, I feel like when somebody sits down, what we need to be doing now is to think like, not just like, how are we going to help you have this one kid right now? It's really like, what are we going to do for a plan to make you have the family that you want in the amount of time that we have? Okay. So, if somebody shows up to us and they're 28 and they have one kid and they only want another one, maybe the pace, and there's nothing that we find, maybe the pace at which they do their treatment would be different than somebody who's 38 years old, who hasn't had a kid and really has their heart set on having 2 or 3 kids. So, I think that, you always want to have in the back of your mind that, yeah, fertility starts to go down in the mid-30s. And that's what I was also saying back to sort of this ovarian reserve idea. If you happen to be somebody who has lower ovarian reserve than other women your same age, that also might be a reason to try to maybe go into treatment a little bit sooner, just so you make sure you have the whole family that you want to have. All right. I wanted to go back. One of the viewers asked a question about, I'm not sure if this is about Mito-Scores. So or if we're talking about, I'll answer the question about Mito-Scores. So basically, on some of there are different companies who will do the embryo testing, and some of the different like genetics companies, excuse me, and some of the companies will do this assessment of the embryo in addition to just the genetics of the embryo, and in addition to sort of like what it looks like underneath the microscope, where they try to assess sort of the integrity of the mitochondria, and they do this thing called a Mito-Score, and they kind of rank the embryos for us amongst the ones that are genetically normal. I have to tell you, I mean, I think it's a little bit of a newer technology, and I mean, I think it's okay to try to use if they're really trying to, if somebody has a lot of normal embryos and they all look nice, it may help us kind of know the embryo to use first, but I think it's still a relatively new technology. We just have like really probably just like another minute or two. Does anybody have any other burning questions that they want to ask? We can always do this again too if you guys want to, but is there any other last questions or anything? Well, listen, I think the fact that you guys came here tonight is really great. I was just telling one of our patients today that, working with infertility patients is always is great because, most of our patients want to do the right thing, want to learn, want to understand, and it's such a joy to be able to like work with you guys and be excited. I'm always excited that people are excited about what we do every day. So I think I'm probably going to go ahead and sign off now. I'm really happy to be here. If the viewers are interested and had a good time tonight, we can always try to set up another time again. And you can always reach out to us on Facebook or Instagram. We have a lot of exciting things coming up in the next coming months. We're going to be moving to a brand new facility. And so that's exciting for us and for you. And so we hope to see you all very soon. And please don't hesitate to send us more questions. Okay? Thanks so much.